I'm Sue Weeks. I'm one of the interventional radiologists from Wake Radiology, and I'm going to be speaking, I'm supposed to speak to y'all today about common leg pains and interventional solutions. Well, just real briefly, because I'm not really saying anything important right now, but as we know, there are a multitude of etiologies for leg pain, and instead of spending a little bit of time talking about each of these, what I'd rather do is spend all my time talking about one thing that is very common in the United States. It affects about 50% of Americans over the age of 40. And so what I'd like to do, Alan, can I go?
Yeah.
Okay, what I'd like to do is present my first and only patient. And this is a 44-year-old female who used to be a nurse. Now she's a sales representative. She has a multi-year history of right lower extremity aching, pain, throbbing. She finds that the pain is worse in the evening. It's especially bad if she's been standing all day. She finds that if she elevates the extremity at night, that the pain is relieved. She has not taken non-steroidal, so she doesn't know if this helps or not. But she also notices that when she wears her support stockings, her legs seem to feel better at the end of the day than if she doesn't wear her support stockings. So we all are kind of thinking about something here, trying to make the diagnosis. We obviously then do a physical exam on the patient. And looking at her leg, you don't really see anything that jumps out at you. Her pulses are intact. She's got 2+ dorsalis pedis pulses. A cursory neuroexamination demonstrates no abnormality. The skin looks essentially normal. There are no areas of skin discoloration or skin thickening. The hair is not lost on the foot. And there is no leg swelling. There's no edema. So pretty much looks fairly normal, like a fairly good-looking 44-year-old leg, actually. But what is important to know is that she can have the exact same disease process that these other two patients have. This is a gentleman, 50-something-year-old investigator for the state. You can see some abnormalities he's got here in his calf. This is an asymptomatic 30-something-year-old nursing student. She's got these abnormalities, and all these patients here have chronic venous insufficiency. So it's important to remember that patients who don't have big varicose veins can still have chronic venous insufficiency. It's an extremely common cause of leg pain. So what is chronic venous insufficiency? Well, normally we have valves in our veins, and this is especially important in our legs because the valves, along with the calf muscular pump, force the blood against gravity back up towards the heart. And when these valves begin to dysfunction, what they will do is the leaflets of the valves no longer oppose one another. And this leaves a space between the leaflets, which allows the blood to then flow with gravity back down towards the feet. This results in pooling of blood in the veins. It results in vein dilatation, and then as the vein dilates more, these valves function even more poorly. And what you end up then oftentimes is developing the symptoms that we've talked about, and we will talk about more, as well as some findings such as patches of spider veins, varicose veins, and then the sequela of these varicosities or of chronic venous insufficiency. So real briefly, I want to go over the venous anatomy of the leg. There are two systems of veins in the legs, and I'm sorry I'm standing right in front of you. But we've got the deep venous system and the superficial venous system. And the deep venous system is the workhorse. It does 90% of the work. It transports 90% of the blood back towards the heart. And the deep venous system is made of the common femoral vein, which starts here just below the inguinal ligament. It then bifurcates, and you can't see these because these are deep, but it bifurcates into the deep femoral vein and what used to be called the superficial femoral vein, which is now just called the femoral vein. The femoral vein continues behind the knee as the popliteal vein, which then trifurcates into 3 paired sets of veins which follow their respective arteries, the anterior and posterior tibial veins and the perineal veins. That's the deep system, that's the workhorse, that's the one that we worry about developing a blood clot in. Then there's the superficial venous system, and that's composed of 2 main veins. This is the great saphenous vein, which runs along the medial aspect of the thigh, continues down the calf and across the medial malleolus, and it inserts at the level of the common femoral vein. So that's its connection, that's one of its main connections with the deep system. And then the second main superficial vein is the small saphenous vein. It runs along the posterior aspect of the calf and continues around the lateral malleolus, and it anastomoses with the deep system at the level of the popliteal vein. Between the deep system and the superficial system are multiple veins called perforator veins, and they connect, they go through the fascial planes from the deep to the superficial system. They connect the deep and superficial veins together. Then there are these communicating veins, and these essentially just run along the superficial aspect of the leg. These are the veins that you can see through people's skin. And this is basically the entire network of veins that you see in the leg. So what are the symptoms and signs of chronic venous insufficiency? Many people can be asymptomatic or only mildly symptomatic. A lot of folks who have massive bulging varicosities really don't have significant symptomatology to go along with those, and that's why these people never go to see a physician for their varicosities. You can have pain, and that pain can either be localized to a varicose vein or it can be diffuse. It can involve the calf, the thigh, or both. Oftentimes patients will complain of an achiness or a throbbing or a heaviness. You can imagine as the blood pools in the lower extremity, the legs start to feel very heavy. Tingling, burning, and itching sensations are also quite common. I also wanted to mention in females with pain, oftentimes this will be exacerbated during their menstrual cycles, and it's felt to be due probably to hormonal influences. So what are the things that we can actually see? Well, sometimes we'll see varicosities. Most frequently we will see varicosities, but it's not uncommon to have somebody just have a few scattered spider veins or really nothing at all. We can see swelling. We can see something called Corona Phlebectasia, and I'm going to show you an image of this in just a minute. Stasis dermatitis, skin discoloration, which is called lipodermatosclerosis in this case, and then the patient can go on to develop terrible things like spontaneous hemorrhage, superficial thrombophlebitis, or ulcers. And I'm going to show you some pictures of these as well. This is the classic image of Corona Phlebectasia. This is a sign of chronic venous insufficiency. This is something that's been going on for quite a while in this patient. Chronic venous insufficiency can affect both the deep and the superficial systems, and when it affects the superficial system, it most commonly affects the great saphenous vein, that big long lane that runs along the medial aspect of your thigh and down into your calf. And so what ends up happening is the patient will end up getting these changes that you see here. They end up with these, I hope you can see, these little spider veins. These are also called spider veins. They're slightly larger and bluish instead of the typical red. But you get these skin changes and these spider vein conglomerates which are localized at the level of the medial malleolus and just below the medial malleolus. That's called Corona Phlebectasia. This image isn't quite so clear, but this is a patient who's got stasis dermatitis. You can see this patch of red skin right here along the inferior aspect of the calf and the ankle. And this is extremely itchy to the patient. You can see he's actually scratched his leg so that he's got some raw areas there. I'm going to show this slide to you twice, or maybe just show it once and talk about both things. This is classic lipodermatosclerosis, obviously with an ulcer involved in the middle of this. The lipodermatosclerosis is this area of skin discoloration. You can see how the skin here has become reddened and brown as well. The skin looks thickened, it looks irritated, there's no hair in this region. This is obviously the more normal appearing skin on this patient. And in these areas, this occurs from chronic influences from having venous hypertension essentially. There are changes occurring in the skin because of the abnormalities seen in the underlying veins. What can eventually happen in these patients who have lipodermatosclerotic changes is this ulcer formation. And commonly these venous ulcers will occur in the medial malleolar region. And it's important to know that approximately 85% of all leg ulcers occur as a result of venous insufficiency rather than arterial insufficiency. Real briefly, just to look at some varicose veins, these are called reticular veins. Reticular veins are essentially those communicating veins that we talked about. They're normal veins. They can become varicose. But these are veins that sometimes can bother people. They can have pain associated with them, and you can see reflux or flow going the wrong way in some of these veins. You can see here this network of communicating veins on the back of this patient's thigh. This is our patient that we just presented with the history, and really the only finding she has is this tiny little blue guy. You can see back here a suggestion of a reticular or a small varicose vein. These are the two other patients that I showed you a minute ago. This is the 50-year-old gentleman who was the investigator for the state. He has pain, and he's got this conglomerate of small to medium-sized varicose veins involving the medial left calf. And this is a nearly asymptomatic 30-something-year-old nursing student. She's got these fairly large serpiginous protruding varicosities involving her posterior calf. And again, this is the gentleman with the ulcer. So how do we diagnose venous insufficiency? Well, obviously we first do a physical examination, and then we almost always proceed to ultrasound. If the patients are symptomatic, even if you don't have the physical findings, you're going to end up doing an ultrasound. When we do an ultrasound, these are extremely in-depth. They take 1.5 to 2 hours to perform if we're doing both legs. And we're looking at both the deep and the superficial venous systems. We look at the deep system to make sure it's functioning normally, because you can have venous insufficiency which also affects the deep venous system. Completely different from the superficial venous system. There are different treatments for it, and we're really not going to talk about it at all today. But we have to evaluate the deep system to make sure it's working normally, that it's not the problem, and to make sure that if the superficial system is the problem, that the deep system is working okay, because if you don't have a normally functioning deep system, your superficial system suddenly becomes much more important than the normal 10% of the work that it does. So we look at both systems, we look at the size of the vessels, and we look for the presence of reflux. The way we do that is we have the patient in the standing position. We have cuffs that inflate and deflate quickly, placed around their ankles. And we inflate the cuff and deflate the cuff rapidly. And what you can see here is the point in time where we have inflated and deflated the cuff. We're insunating the great saphenous vein, and this is blood flowing normally towards the heart. Once the cuff is inflated and deflated, you can see that blood is now flowing in the opposite direction, so it's flowing away from the heart here. And what we do is we time how long this takes to turn back to normal flow going back towards the heart. And you can see here, from this level to this level, which the flow still hasn't returned back to flowing towards the heart, but it's close enough that time is greater than 8 seconds. So at least for 8 seconds after we've squeezed that calf and let go, blood is flowing down the leg instead of up the leg. So that's extremely abnormal. Normal is less than half of a second. And then this is just an image of a great saphenous vein located within the saphenous sheath. It's enlarged, but otherwise appears normal. It's sitting in the superficial plane of the leg. This is the deep compartment of the leg, and then the skin would be sitting up here. And this is the appearance that we're looking for: enlargement of the vein and then reflux within the vein when we perform this part of the examination. The treatments that we have available to us for venous insufficiency are conservative treatment. This is pretty much what everybody has to go through first, unless they've got one of the terrible complications of venous insufficiency, and that includes an ulcer, superficial thrombophlebitis, or 2 incidents of spontaneous hemorrhage. Conservative therapy is required by the insurance companies. What the patient has to do is 3 months of 30 to 40 millimeter compression stockings, avoidance of the activities that cause the symptoms to occur, if possible, the use of non-steroidals if possible, and elevation. Once the patient fails conservative therapy, and most patients do, A, because they're either unable to wear the compression stockings for prolonged periods of time, or B, because you're not really fixing the problem, you're just compressing the blood out of the leg so that they're not having the same symptoms that they normally would they not be wearing the compression stockings. We can then move on to a more aggressive therapy. And this used to be vein stripping in the past, but pretty much in most communities this has been done away with, and more often what's performed is catheter-based percutaneous heat ablation of these veins, and that includes the great saphenous vein and the small saphenous vein. So for larger veins, we currently are using, in general, catheter-based percutaneous heat ablation of these veins. We can also do what's called an ambulatory phlebectomy, and that's an actual removal of the vein, much like the surgical stripping is, but we have changed the name of it so it doesn't sound quite so bad to the patient. We also, every once in a while you get a smart patient, they say, doesn't that happen? Doesn't that sound just like surgical stripping? No, it's much different. It's ambulatory phlebectomy. We also can do sclerotherapy on a multitude of sizes of veins. We can do sclerotherapy for teeny tiny little spider veins up to very, very large veins. And interestingly, in Europe, the insurance companies will pay for sclerotherapy for very large veins. In the United States, the insurance companies won't pay for sclerotherapy for very, very large veins, in general. That's kind of a gross generalization, but let's just go with it for now. And so in Europe, they will perform foam sclerotherapy to ablate the great and the small saphenous veins. If we did that here in America, we wouldn't get paid for it. So in America, people have created radiofrequency generators and laser generators so that we can burn the vein with expensive generators and catheters, and then the insurance companies will pay for that. So both procedures work very well. In the United States, though, we've currently got to do a catheter-based procedure. In Europe, they can do sclerotherapy. Real briefly, like I mentioned, you can perform radiofrequency, heat ablation, or laser ablation of large straight veins. And neither entity has proved to be more useful than the other. They both work very well. It's pretty much user's choice and which representative got to you first. So this is kind of the tools that we use when we do laser ablation. This is the sheath. It's very small. This is my Bic pen. This is the sheath that goes in the vein. This is the laser fiber. This is a close-up of that, and you can see the laser fiber is really quite small. That goes through the sheath and into the vein, and then we burn the vein, and I'm going to show you a little example of that here. So we perform this, can be performed in an inpatient setting, in an outpatient office setting, or in a hospital setting, but it's usually performed just with Xanax on board. Some people do it with conscious sedation, but in general, it's not performed with conscious sedation, and the patients don't really need it. The way that we do it is with ultrasound guidance. The leg is prepped and draped as we normally would. We then usually access the vein. Usually it's the great saphenous vein at the level of the knee or slightly below. We run a wire up the vein to the level of the common femoral vein, run the sheath over the wire, put the laser fiber through the sheath, and then position it so that the tip of the laser fiber is about 2 centimeters peripheral to or inferior to the saphenofemoral junction, because we don't want to burn the deep system, we just want to burn the superficial system. And so this is our ultrasound image in longitudinal during a procedure. This is the common femoral vein. This little white blip you can see right here is the terminal valve which divides the common femoral vein from the saphenous vein, and then this double white line is our laser fiber. So the tip of our fiber is here, and the terminal valve is here. So we're well within the great saphenous vein there. Then what we do so that the patient doesn't feel this laser going off in their leg is we use a tumescent anesthetic. It's a very dilute anesthetic which we then administer under ultrasound guidance all along the length of the vein to be treated. And then how that ends up looking is here. This is a transaxial image of the great saphenous vein. This is that same Egyptian eye sheath that I showed you a little bit ago. This is not the vein. This is that tumescent anesthetic, the black stuff. So it's surrounding the vein. This is the vein wall, and this bright echogenic thing is the laser fiber. So we've got laser fiber, vein right against it, and then tumescent. The reason we put the tumescent in there is A, so the patient doesn't feel the procedure, B, so that the vein is pretty much scrunched down around the laser tip so that all the heat that we generate will go directly into that vein wall and won't get dispersed, you know, having to travel a far distance to the vein. And then also so that we have provided ourselves with a safety margin, basically, so that we can avoid non-target burns, essentially. Can we promise it? No, but in general it doesn't happen. But you can imagine you could theoretically develop a nerve injury here because you can't see the nerve fibers, obviously. It doesn't happen very frequently. This is just a schematic of what I just explained to you. Once you get the fiber up, you turn the fiber on after you've administered the tumescent, you pull the fiber down, and you end up burning that vein. The vein immediately is not occluded, although there very uncommonly will be flow in it. It's just very, very, very irritated. You've just burned the heck out of it. And this is the common appearance of that vein. It's called the donut appearance. It's a thick-walled vein now with a tiny little lumen remaining in it. This is some of that residual tumescent anesthetic, and a lot of it will go into the surrounding soft tissues. And then in follow-up, we'll get an ultrasound examination, and what we want to see is we want to see flow in the common femoral vein. We don't want a DVT. We want to see flow in a little nubbin of the saphenofemoral junction, and then we want to see occlusion of that great saphenous vein. So again, just real quickly, this is the pre-appearance of the great saphenous vein, normal appearing except it's enlarged, and then immediately after the burn, it's got this Homer Simpson donut-looking appearance to it. So after the procedure, what do we have the patients do? We have them get up and walk immediately. We want them to go back to all their normal daily activities except no heavy exercise. There are 3 things we're trying to avoid. We want to avoid pain. We do that by giving the patient 800 milligrams of ibuprofen 3 times a day, and that's to fight that inflammatory pain that they're definitely going to see because you've just set a laser off in their leg. We want to avoid a deep vein thrombosis. So we have the patient walk, 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 and we have them wear compression stockings, those same horrible compression stockings for 2 weeks after the procedure. That is also to help us keep the vein walls that we've just treated close together. We don't want blood to get back in there because if blood gets back in there, the vein will not grow together. They'll get a blood clot in there, then they'll get a superficial thrombophlebitis, and it will hurt like heck. So we keep the blood smushed out of that vein and allow that vein to fibrose together, and that usually takes a couple of weeks or so. Avoid non-closure. The way we do that is with that compression I just talked about and no vasodilatation, so no heavy exercise for 2 weeks. But if these patients want to walk 5 miles a day, we're all for that. What I want to talk about next is ambulatory phlebectomy, because we commonly perform ambulatory phlebectomy at the same time that we perform the laser procedure, and then I'm going to talk about the complications of both of those. When we perform ambulatory phlebectomy, we always have the patient standing up first so that we can distend the veins as much as possible. We have the patients demarcate the veins that they'd like to have treated, and then we go ahead and mark those veins while they're in the standing position, because once they lay down, the veins oftentimes will not puff out so much anymore. We then administer that same tumescent anesthetic at the same time that we do the procedure on the great saphenous vein or the small saphenous vein. And then we make tiny little skin nicks, about 2 to 3 millimeters, right along the vein. We go in there with one of these hook instruments and hook that vein and pull it out through the skin. If we get a big piece of vein, we go a good distance and make an incision further away. If we get a little piece of vein, we make an incision a little bit closer to that first incision that we made. So it's not rocket science. We even oftentimes end up leaving pieces of vein in there, but in general the response is very, very good. So after the procedure, again, we have them wearing the compression stockings. That's the other reason that we perform the two procedures at the same time, so that they just have to wear the compression stockings again one more time. They wear the dressing for 48 hours. They walk, walk, walk. They take the ibuprofen for pain just as before, and they keep the leg clean and dry, obviously. So this is our patient pre, and this is our patient 1 week post. She's got some bruising and stuff, but overall it looks much better. And these patients feel better, basically, even though they're having the pain that we've caused from the procedure. They are feeling a lot better. That leg heaviness and achiness is gone within a week. It really is remarkable. This is another example of a 60-something-year-old woman that we did the endovenous laser ablation of the great saphenous vein, and then we removed these varicosities involving the anterior lateral medial thigh, lateral knee, and then anterior and lateral calf. And that's the pre, obviously. I hope you can tell. And then this is the post, where her leg looks a lot better, and she felt a lot better. So complications of both of these procedures are somewhat overlapping. For the laser ablation, anytime you break the skin, you have to worry about bleeding or infection. Deep vein thrombosis, like I said, is the big one that we worry about. It's extremely uncommon. It happens extremely rarely because we're doing everything we can to not have it happen. But anytime you have a procedure done, you always have to worry about developing a deep vein thrombosis. You can have a non-target burn, like I mentioned, skin burn, nerve injury, and there's been one case report of where a femoral artery sat too close to the saphenous vein when they burned it. The heat dissipated across and made an AV fistula between the two, and that had to be repaired. So that's one case, though, but it's something to keep in mind. And then the patient, like I mentioned, can develop a thrombophlebitis. Clot can form in that vein. That can be very painful, but it's usually self-limiting, lasts a day or so, but it can be very, very, very painful. For ambulatory phlebectomy, the complications include bleeding and infection, obviously. They can also develop a thrombophlebitis if a small piece of vein is left in there, but that's usually, again, self-limiting. And you can imagine with that little hook, sometimes if you pull something out, it might not be a vein. That's uncommon, too, though. So the outcomes, this is a pretty good paper that generalizes what the experience has been for this procedure. Dr. Min from Cornell back in 2003 wrote a paper looking at 497 great saphenous veins that they burned, and they found that they initially had occluded 490 of them, so that's a very good response rate. What they found is they had a 6.6% recurrence rate at 2 years, and this was detected by 3 months. So in general, if you're not going to close, you're not going to close right off the bat, and then those are the people who are going to be treatment failures. You don't often close and then have the vein reopen because it fibroses and goes away. Now you can have revascularization or neovascularity, which can occur, which is one of the problems with surgical stripping, is once you start mucking around in the groin, new vessels like to form, and a lot of vessels can come and take the place of the vessel that you've just treated. So that can happen, and it's always important to let the patient know that that can happen. And their only complications were bruising and tightness, and some of these people can have some significant bruising. Am I doing okay on time? Okay. The next thing I'd like to talk about is sclerotherapy. Again, we can use sclerotherapy for both the very, very smallest veins and quite large veins. There are 3 ways to perform sclerotherapy. It used to be it was all performed visually. You used your eye, you saw the vein, and you poked it. Now we have transillumination devices, things like the vein light, which some people use for starting IVs, where you place the device on the skin. It helps illuminate the vessel, and then you take your little 30-gauge needle and poke it right into the vein, and you can actually see yourself if you're extravasating the sclerosant into the surrounding soft tissues. And then we can also use ultrasound guidance for the deeper veins that you can't see above the skin. And we just use ultrasound, stick the needle directly into the vein, squirt the sclerosant into that vein, and you can see it go directly into the vein. So that's very reassuring. Again, you can treat spider veins as small as 0.3 millimeters and even smaller, basically whatever you can get just the tip of the 30 gauge needle into, and then you can treat larger veins up to greater than 10 millimeters if you use a foam sclerosant. There are now 2 ways to do sclerotherapy. One is with a liquid sclerosant, and the only one that's currently FDA approved is in the United States is Sotraticol. Hypertonic saline is commonly used, and it's been used forever, and it is a standard of care, so it in general is okay to use, but it's not FDA approved for sclerotherapy. And then there's some other liquid sclerosants which also are not FDA approved. Foam sclerotherapy is not FDA approved either. So you can take the same FDA approved sclerosant, which is Sotraticol, and make foam out of it. And the way you do that is you take 1 part of Sotraticol to 4 parts of air or CO2. You take 2 syringes and just push it back and forth between a 3-way stopcock for about 30 seconds, and it creates a foam. Once you've changed the nature of the chemical, it's no longer FDA approved for use, but it's being used all over the United States, and so again, it is a standard of care. The foam sclerosant is used in the larger vessels. The liquid sclerosant is used in the smaller vessels. You can imagine if you now have a foam, when you inject the foam into the vein, it can touch all of the vein walls better, especially in these big veins. If you're trying to pump enough liquid sclerosant into a 10 millimeter vein, you can kill somebody. You know, you're changing their blood into sclerosant. But if you use foam, you can use tiny, tiny little volumes of foam and hit all the vein walls. So you're just trying to irritate the vein just like you do with that laser ablation or radiofrequency ablation of the vein. You're irritating the vein walls, and then you're compressing them together so that they will grow together over time. So sclerotherapy is a process. It's an injection process. The vein doesn't just beautifully disappear right in front of your eyes. These people come in and say, I have a wedding to go to in 2 weeks, and you just think you're in deep trouble, baby, because your legs are going to look terrible in 2 weeks. We tell everybody, your legs are going to look horrible. You're going to have terrible bruising. You're going to think I've destroyed you, and it's going to take a long time. The bruising goes away in a couple of weeks, but the veins go away over time. They fibrose slowly, so they don't just magically disappear. Some patients are kind of sad to hear that, and initially when I learned how to do this, I was too, because they show these beautiful pictures. You inject a sclerosant in the spider vein turns white, the patient says, ah, and then the spider vein comes right back, you know, and then they're mad. So it's that it just never went away. It takes time for this to go away. So we tell people you may require multiple treatments to make these things go away. You can't expect it to happen in one treatment. Also, the same patient may have wonderful response in one set of veins, and the other set of veins in that same leg may not respond quite as nicely. We have no way of knowing who's going to respond how. The complications associated with sclerotherapy, with liquid sclerotherapy, the 2 that are not so medically important and are more common are telangiectatic matting, which is the formation of tiny little red 0.3 and less millimeter veins that can mat in the area that you've just treated one of these veins. That happens in 30% of people, but it will go away essentially in everybody, but it may take a year to do so. And hyperpigmentation is the other thing that's not so medically important, but cosmetically it is. Again, it occurs in about 30% of people. They can develop dark spots or lines in the area that you've treated a vein, and that can take up to a year to go away. And this can be fairly distressing for the patient if they're having this done for cosmetic purposes. The things that we worry about more are blood clot formation and ulcer creation. These are extremely uncommon, but if they happen, they're fairly disastrous. They will heal. You do treat for DVT, 6 months of anticoagulation, but this isn't why you're performing this procedure for somebody. Foam is a little more dangerous. Complications that have been associated with foam include chest tightness, visual disturbances, headache, and a stroke has been reported. Sclerotherapy, after the procedure, we have the patients again wearing the compression stockings for 2 weeks. Is to keep those vein walls opposed to one another so that the vein can fibrose and go away. We have them walk, walk, walk. We have them doing no heavy exercise for 2 weeks because we don't want them to vasodilate. Avoiding blood thinners because we don't want them to have increased bruising because this can lead to worsening hyperpigmentation. And we tell them don't be tempted to come back in 4 weeks. Wait the full 8 to 12 weeks if you can, because this is a process and there is a good chance some of these veins are going to go away. We also have them avoid sun exposure so that they don't get this hyperpigmentation that we just talked about. So in summary, chronic venous insufficiency is an extremely common problem. You have to think about it even when you see somebody who has, quote, normal looking legs. It has many presentations, and there are multiple evolving treatments that we have available to us. And I have to torture y'all with my kids. Does anybody have any questions? Yeah.
Did you say that 2 episodes of hemorrhage was an indication medication for repair that insurance companies will cover?
Oftentimes, it's insurance coverage dependent, and I don't know the specifics of who does what, but in general, 2 incidences of spontaneous hemorrhage, yes, will warrant you a direct, you get to pass the conservative therapy. Yeah?
And I've got the impression that the sclerotherapy that's done in Europe is just as effective. We just can't do it here because of the insurance, and it seems like it's an easier, more accessible.
Well, so I kind of glossed over that for the sake of time, but in Europe, they oftentimes they can do catheter-directed ablations of these straight big veins, but they will much more frequently perform foam ablation of the larger veins because insurance will cover it. But it actually has been proven to not be as effective. It's averaged out to be something like 1.7 treatments for full closure of the vein. Europeans are willing to do that, though. You know, what you'll see is sporadic closure of the vein, and then they'll come back and fill in the spaces that they missed the first time or that the foam didn't quite do the job. So it works, but it doesn't work quite as well. But once you get rid of the vein is gone.
But less expensive.
Much less expensive, because foam, the foam costs $30.
That seems funny, but
It's ridiculous. And it's actually more safe because there are lots of people who are, I'm just blind to myself, who are burning the great saphenous vein down in the calf. And that is doable, and it's fairly safe, but there's a nerve that runs along that, and you can burn that nerve. So that's one reason to put that tumescent anesthetic in. But with foam, you don't so much have that problem. You can just inject that vein and not have to worry so much about having nerve damage. So we're trying to get, it's actually better, exactly. So we're trying to get foam okayed in the US, but that's a long process.
keep working.
Yeah.
How often are you treating more than one vein, such as like an anterior thigh, in addition to the brain, and are you treating for brain damage?
How long are we treating?
How often do you treat like a brain with the anterior accessory? And are you treating for
In general, you treat one at a time. And that's a little inconvenient, but because it would be nice if you could use the same laser fiber for everything. But what ends up happening, like I mentioned, there's a great debate as to whether or not you should be doing ambulatory phlebectomy at the same time that you perform the burning of the vein, or however you're going to get rid of the vein. And we choose to do both at the same time because it's been shown that about 30% of veins will, quote, go away on their own and don't require ambulatory phlebectomy. And when you tell people that, a lot of people say, if this means I have a 70% chance of this vein needing treatment later, I'm going to go ahead and have it done. So what ends up happening is they're on the table for about 3 hours. And by that time, everybody's done. So in general, we'll treat one main vein, although you could treat a couple, and then we'll do the phlebectomy, and then we'll do the next leg if they need it in 2 to 4 weeks' time or whenever they want to have it done.
Thank you, Susan. Well, I don't know about you, but I'm walking home today.